Hello everyone, my name is Magella Daly. I'm the Assistant National Director in the National Centre for Clinical Audit, and I'd like to welcome you to this webinar, Charting Impact, Unveiling Clinical Audit Activity in Child and Adolescent Mental Health Services and Intellectual Disability Services, coming from the HSE Southwest Regional Health Area. I'm launching this webinar during Clinical Audit Awareness Week 2024. So I'm delighted to be here presenting today with colleagues from the HSE Southwest region, and they are Caroline O'Connor, Quality and Safety Advisor within Mental Health Services, Sylvan Varasu, Clinical Coordinator, South Kerry CAMS team, Mary-Louise Sheehy, Quality and Patient Safety Advisor with Disability Services, and Anthony Brennan, Clinical Nurse Manager 3 with St Raphael's, a residential care centre for adults with intellectual disability. The purpose and learning objectives for today are to showcase learning from this region. This is based on feedback from staff in the HSE looking for advice and support around the experience in mental health services and disability services for clinical audit as we move towards implementation of the region's under Sláinte care. We want to promote clinical audit activity in child and adolescent mental health services and intellectual disability services, and we want to share experiences from those services for future regional and local audit programs. I will now hand over to Caroline O'Connor from Mental Health Services.
Hello, I'm Caroline and I'm here today with my colleague Sylvan, and we're going to present learnings from the Maskey report in the context of clinical audit. In January of 2022, Dr. Sean Maskey published a look-back review report after assessing the care received by children and young people attending the South Kerry CAMS service between July 2016 and April 2021. The look-back review report outlined 35 recommendations to be implemented. These recommendations would address the findings raised in the report in order to improve the service user's experience, to re-establish trust in the service, and to improve the delivery of clinical services within the area. Recommendation 15 reported that audit training must be provided to the team by the Quality and Safety Department within the CHO, and an annual audit schedule established by CAMS teams. Service users should be consulted and included in the audit oversight group. CAMS appropriate audit tools should be developed, and audit activities should be organised across all CAMS teams in order to share understanding and develop collegiate thinking for the service. So what has happened so far? Clinical audit training has been completed by all the relevant team members within the CAMS service, and the requirement to undertake this training is identified at the local induction stage for all new staff coming to the team. A clinical audit schedule has been developed which prioritises audits that will provide assurances on the implementation of the Maskey recommendations. The Clinical Audit Committee is chaired by the Clinical Coordinator. Clinical audits are presented to the Cork Kerry CAMS Governance Group as part of the oversight and governance process. Quality and Safety Advisor is now a member of the Clinical Audit Committee to support this function. I'll now pass you over to my colleague Sylvan.
Hi, my name is Sylvan Varasu, Clinical Coordinator for South Kerry CAMS team. I'll be talking a little bit about the audit completed so far the year 2024. We have recommendation 11 around the Maskey recommendation. These based around the key working policy audit, recommendation 13, healthcare records audit, recommendation 23 and recommendation 25 based around medication prescription and medication consent. This is part of the wider national audit around prescription completed in 2021 and published in 2023. And one of the recommendations that come out of that is for local services to re-audit prescription. So we have then recommendation 27, which is based on our fiscal monitoring. Recommendation 29, patient-reported outcome measures audit, otherwise PROMs. And last but not least, recommendation 30, which is individual care plan audit. Now I'm going to talk a little bit about work in progress, so I guess where we are so far. Using the National Clinical Audit Terms of Reference to formalize governance and reporting structures for the Clinical Audit Committee in the context of the new regional health area structure, the Terms of Reference will explicitly detail the communication between the local audit committee and senior management teams within the regional health area. Next will be about setting out the process for submission, prioritization, approval, and registration of local clinical audits. We're then going to be looking at identifying a lead for clinical audit within the service to work with the quality and safety advisor and the department. First, to explore the potential of implementing a clinical audit ICT solution. And two, to source, develop, and standardize audit tools. Next, we'll be looking at the scope out the process for service user involvement in clinical audit oversight group. Develop an evidence-based annual clinical audit schedule for the service. Complete training needs assessment to determine which staff should complete which level of clinical audit training modules as relevant to their role. Face-to-face training is in development to complement the NCCA online fundamentals clinical audit. And last but not least, a quality street visual board will be utilized within the service to inform staff of the upcoming audits and audit results. I'll now pass you on to my colleague, Mary-Louise Sheehy.
Good afternoon, everyone, and my name is Mary-Louise. I'll briefly describe the intellectual disability service we're talking about today. It consists of 5 HICWA designated centres. 4 of these are community houses where individuals are supported by staff to live in their own home. 1 designated centre is a purpose-built high-support residential service for individuals with an intellectual disability and/or autism or acquired brain injuries. The service is regulated by HICWA, but we're conscious that these centres are individuals' homes. As you know, clinical audit is an essential quality improvement process that aims to ensure that those individuals that we support with a disability in our service do receive high-quality, safe care. HICWA's national standards for adults with a disability is one driver for quality, and clinical audit is a priority area of work for the service and the staff within it. Also, the process of audit is part of a framework of clinical governance, whereby organisations are accountable for continuously improving the quality of their services and safeguarding high standards. I'm now going to take you again briefly through some of the work undertaken to enable clinical audit in the service. The factors that enable clinical audit are well documented and are not necessarily unique to disability services, but it is important to understand how they apply to your service. There is a commitment to clinical audit training for key staff in the service. So the fundamentals of clinical audit is completed by those staff responsible for doing the audit, and the quality and safety advisor is available as a further source of support. Each designated centre identifies and publishes their clinical audit schedule, and clinical audit comes under the governance of the Services Quality and Safety Committee. There is a clinical audit committee as a subcommittee of this Quality and Safety Committee, and its purpose is to deliver on the structures and processes for clinical audit to ultimately provide assurance. That is, to answer the question, are we doing what we're supposed to be doing? How well? Are we identifying areas for improvement? And are our plans to improve delivery? The resources are those staff who are undertaking the audits, the work of planning and prioritising the audits and the audit schedule, and the work on standardising audit tools across the centres. Approval has been granted this year to introduce a clinical IT solution to further enable clinical audit activity in the service. This slide gives you some examples of clinical audit topics currently undertaken in the service. Some of these are already well established in the schedules and have been ongoing for a while, so we can track our performance. Others are topics which we have identified as needing to be added to the schedule. Topic selection follows the same approach as outlined in the national guidance, with such questions used, for example, as, is it an area of high cost, high risk, or high volume? Is there evidence of variation in practice? Are there reliable sources of data? And does the topic lend itself to the audit process? I'm now going to pass you on to Anthony Brennan. Thank you.
We have faced many challenges in developing an audit culture within the service. Understanding the benefit and value of clinical audit to the service was a key priority. We understood that there was competing priorities for each key stakeholder. It was essential that we knew what we were trying to achieve and how clinical audit could help. This reinforced to all key stakeholders that clinical audit is a worthwhile use of their resources. To address the lack of expertise in audit design and analysis, the development of audit skills for key stakeholders through training and the support of the quality and safety advisor was essential to enable us to develop an audit process to focus on key areas which would benefit from clinical audit. This increased knowledge enabled us to develop audit questions which were clear and targeted, Key stakeholders developed the skills to effectively analyse the findings from the audits, which enabled the development of smart plans, which, when we audited, we could monitor how effective they were and a result of closing the loop. Group members have differing priorities, agreeing on a standardised audit tool, developing clear audit schedule enabled us to identify a baseline, which was a key first step. On identifying the areas that required addressing, we were then in a position to prioritise key areas to develop a re-audit schedule to monitor the impact the agreed action had on service delivery. The organisational impediments included manually held paper-based records and paper-based audit tools, which impacted the efficiency and effectiveness of data collection, and also resulted in challenges in monitoring progress with actions. We have learned of the importance of maintaining our focus of what is the purpose of clinical audit, which is to identify improvements which will enhance the life experience for each individual. The key steps to obtaining reliable data were consistency in how the sample will be selected and also the sample size. Staff who completed the audits reported that they welcomed a consistent audit template for all audits, with each audit having a clear, concise and simple questions and a familiar or smart action plan. The importance of re-auditing to monitor impact of actions and compliance was essential. Our experience has highlighted that clinical audit has been invaluable for identifying areas which require change and has been key to continuous quality improvement. The involvement of all key stakeholders was very important. A clear governance structure with a commitment to maintaining focus, developing and maintaining an audit culture, ensured ongoing focus on clinical audit by offering oversight with compliance with agreed audit schedule and monitoring of progress with action plans. Finally, something that was initially overlooked, the involvement of frontline staff through providing feedback and learning from clinical audits to all members. This was identified as being a great benefit in enabling this learning to be shared to improve the service we offer to each individual.
I would like to conclude by thanking all the participants and presenters here this afternoon, Caroline, Sylvan, Mary-Louise and Anthony. I would also like to thank and acknowledge the heads of service who supported this work, Annette Logan, Head of Service for QSSI, Angela O'Neill, Head of Service for Disability Services, and Julie O'Neill, Head of Mental Health Services. I would also like to draw your attention at the end of the slides to all the various information that's available from the NCCA, and thank you all for participating in this webinar during Clinical Audit Awareness Week.